Just 1 minute. I'm starting your time. Okay. So start. 6 minutes total.
Okay.
Abnormal movements. Examine the lower limb and relevant. Okay. I'm showing you the video of the,
Absent with.
yes.
What is
This
this?
this is a
Uh,
child who is 6 year old and
okay.
examine the lower limb and relevant
Lower limb and relevant.
and relevant.
Okay. I will. I will. I should start from here. That I will enter
Yes.
the room.
Yes.
I will enter the room and introduce myself to the examiner, and I will give my mark sheet to him.
Yes.
Then, after entering the room, I should wash my hand, introduce to the mother, and
Introduce yourself.
make.
How will you
Yes,
introduce?
yes. My name is Dr. Muhammad, one of the treating doctor here. I will examine John today, and I will take some notes if you don't mind.
Uh,
While
you
making a
cannot
repo,
you cannot make notes during your clinical examination.
okay.
I mean, yes, you can keep you have to do the
Just only
examination.
introduce that I am Dr. Tanvi, one of the treating doctor here. Today I will examine John, and
Okay.
while making this repo, I should
Okay.
also ask John, hello John, how are you? Please show me your lovely smile. And also, I should shake hand with John in both hands.
Okay.
Then I will
So
take permission from his her mother to examine the Johns.
okay. First,
On
you will take.
examine
Hmm. Okay.
After
Do it.
taking permission, first of all, I should make a general observation of John. That what about his head size, shape, any shunt, any scar mark on his head or any body, any squint, any abnormal speech pattern, and any abnormal movement, uh, any abnormal
No abnormal
gait,
movement.
no abnormal movement. Okay.
Okay. Hmm.
Then any dysmorphic features, any device attached to him or in the surrounding, I should make observation. Then after this, I have to expose because my command is lower limb, so I have to
Yes.
make a proper exposure. Proper exposure like his remove his socks and shoes, and also make his trouser up to mid of thigh. Then
Okay.
I have to check his gait
Okay.
of the
So
patient, which I
this
have
is the
seen in
gate.
the video.
Yes, this is the gate.
Uh,
All right.
yes, this is the gait of 6 years old John, who has while walking has one right-sided
Okay. That you will tell.
circumduction
You will
gait
tell. You will tell that on description. Okay. So you have checked the gate.
gait, then also back of John and back of the lower limb. After
Okay. So
this,
what do you want to see on the back of lower limb?
uh, on back of lower limb, I would want to check any scar mark, any
No scar
skin
mark.
pigment. Okay, no scar mark, any skin pigmentation,
No skin pigmentation.
any hypertrophy or wasting of muscle.
No hypertrophy. There is
Okay,
wasting on the right side,
and
the lower
any
limb.
abnormal posture of while walking.
This you can see here.
That he has, yes, okay, circumduction gait.
Okay.
And about his upper limb, posture of his upper limb, of his arm and hand.
Yes.
Then I should ask the John to lie on the bed and take limb length discrepancy.
Limb length discrepancy.
Yes,
Okay. So there is no limb length discrepancy.
no limb length discrepancy. Okay. Then I have to start for this local examination. First, I have to do inspection of the lower limb properly, see any scar marks, skin pigmentation,
I told
and
you not
then
present.
I have to go for his power,
Power is decreased on the right side.
decrease on the right side.
That is
He's
3 by 5
walking.
on the right side and 5 by 5 on the left side.
Okay. And, and then I have to go for his tone of the lower limb,
Tone is increased on the right side and normal on the left side.
normal on left side. Okay. What about reflexes of the right sides? Increase or
Okay, right side, they are increased on the right
increase
side
right
and
side?
normal on the left side.
Okay. And what about his Babinski? I will do plantar,
Plantar is up going on the right side and normal on the left side.
normal on the left side. Okay. After this, I have to go for coordination.
Coordination,
Can he do
6 minutes done.
coordination? What?
Which test you will perform to do the coordination?
Heel
6 minutes
chin
done.
test. Yes, heel chin test.
Heel chin test.
That
Okay.
after when he lie on the bed, we can say that
That is
put heel, toe or heel like this. I have seen
okay. That is normal on the left side, but he
normal
has
on
some
the left
difficulty.
side.
Yes.
Okay.
6 minutes and
Then
30 seconds done.
okay, and also I have to see his this um, on the. I have to check his the other limb, upper hand, upper limb in. I have to check for power.
Okay. Right sided power that is 3 by 5. Left side is 5 by 5.
Okay. Then I have to cover the patient and thanks the patient. Then I will
Okay.
tell my examiner that today I
Okay.
examine
Describe your
6 years.
findings.
Yes, today examine 6 years old John who has a problem in the right side walking in the while he's walking he has a circumduction gait while his knee is extended and make half circumference while walking and his arm is flexed and has a fog sign on the right side while on the normal side is on inspection he has no skin pigmentation, no scar marks, no hypertrophy. And on the right side, power is decreased 3 by 5. On left side, normal power, similarly tone. On right side, increase and normal on left side, while reflexes increase on right side and normal on left side, uh, positive plantar on right side. So putting
O-
all together, I think that this is right side hemiplegia.
Okay. Anything else you want to perform in your patient?
I would like to complete my examination to do his cardiac examination and this cardiac examination, abdominal examination,
Why you want to do abdominal examination?
Because in some time there's chances of uh, tumors or malignancy or thrombosis.
So which tumor you are suspecting for abdominal examination?
Actually, in this case, there's a organomegaly can occur because of malignancy, also lead to this stroke, like splenomegaly,
Okay.
hepatomegaly. Yes.
Okay. Anything else you want to perform in this patient? Anything else you want to
We got
do? Okay. How? What is your
coordination.
diagnosis?
Hemiplegia, right side hemiplegia.
What is the cause of hemiplegia?
Cause of it can be stroke,
Okay. So
serious
what is the
cerebrovascular
cause of the stroke?
accident.
Okay. What else?
It can be due to some thrombosis, hemophilia, homocystinuria.
Okay. So you are suspecting homocystinuria in this case.
No, because I did not ask about his
Okay. How will
mail.
you investigate?
I will investigate from this because it can be due to infection, full blood count, ESR, CRP, and
Okay.
I will also do this. It in sickle cell anemia, it also can be occur. So I have to do hemoglobin electrophoresis and
So do you suspect John is having like sickle cell anemia on your examination?
no, not
Not really. So
yes.
why would you go for electrophoresis?
Because it can cause stroke in some patient. But here I would go for MRI brain or CT scan.
Okay, how would you manage the case?
Regarding management, I will take full history and make investigation. I will involve multidisciplinary team. In multidisciplinary team, neurologist, physiotherapist, occupational therapist, cardiologist,
Okay.
hematologist, nephrologist, and this school
Why
liaise and
why
sport
nephrologist? Why nephrologist here?
because nephrotic syndrome can also lead to this stroke.
Okay. Do you see any abnormality in the zone for nephrotic syndrome?
Apparently, no finding.
Okay. Okay. All right. So if there is no finding, why you will involve nephrologist,
Okay.
right? Okay. How would you manage? So one thing that you told, that is about the multidisciplinary team. All right.
Team, yes.
Okay. What else?
Physiotherapist
Okay.
and occupational therapist
Occupational therapist.
and
Okay.
what kind of it's,
Neurologist.
social support neurologist,
Okay.
social support to family,
Okay.
and
What
liaise with
else?
school. What?
Okay. What else? Uh, Besides this
Hemat.
multidisciplinary team, what else you would do with this patient? Okay.
Um, uh,
let us start discussion of this case. All right.
Okay.
So, Dr. Tanveer, what is blood pressure of your patient?
Yes, I did not ask about
Okay.
blood pressure.
Okay.
Vitals.
Okay.
I will take vitals and
Would you like to go for fundoscopy?
yes, I have to go for endoscopy to see for papilledema.
Papilledema.
But
Okay.
yes, I did not.
All right. What was your command? What was your task?
Low limb abnormal movement. Examine the lower limb and
Okay. So
relevant.
examine the lower limb and relevant. But you started with your head size measurement. I would like to expose, I would check the head size, I would like to check for the squint, I would like to see is there any device that has been attached or not. Okay, so
Yes,
what was your command, what was your task? Examine the lower limb and
lower limb
relevant. Okay,
relevant. Yes,
you have measured the head circumference, you have looked for the squint, that is very well, but you should have start from the lower limb inspection and examination. Okay,
okay,
eye examination had circumference measurement, that was a part of the relevant examination. All right.
okay.
Okay. You started with
Yes,
your introduction. My name is Dr. Ahmed, and I want to. No, you will not say I will check John. I want to check John. Is that okay with you? It's like you will take the
yes. I
payment.
want to check, John. It is okay. Yes,
Is that okay? Okay. During your clinical examination, you will not have time to write down. You can write down the blood pressure, height, and weight if you have checked, if you have asked from the examiner. But you will not ask. I will write some notes.
I will
Why?
write it.
You will just
Actually, cannot.
notice.
Yes, this one. This.
Okay. All right.
Yes,
The one thing was that write down the words for your introduction. My name is this one, and I am a
yeah.
pediatric registrar or working doctor here. I want to check John. Is that okay? So these are the lines for the consent. So it means I need to improve my way of asking the consent. Okay. The second
Consent.
thing is a
Okay.
very good point was that you shake both of your hand with the patient, but you didn't ask me, is there any change in the power of both hands? Okay. John, can you
Okay.
please smile for me? Okay. So when the John was smiling, when there was a hemiplegia, you should have a certain, is that crossed or uncrossed hemiplegia? Okay.
Yes, cross and
So
uncross. Yes,
you didn't ask me for like how is the smile, so that is why I didn't tell you. Otherwise, when you will examine the patient by shaking both of your hands, especially in these cases where this is a case of the hemiplegia, CNS abnormality, there will be less power in one hand. And when John is smiling, you should see where is the deviation of the mouth to
facial
one side or
deviation.
not.
Yes,
Yeah,
yes,
facial definition. It's not just the repo building. Along with
mm,
repo building, you have to see, is there any cranial nerve, facial nerve palsy or not. Okay.
yes, yes.
Okay, so my command was do the lower limb examination. So first of all, I will take the consent from the parents, from the mother, from the John if he's interacting. Then I will shake both my hands with the John. Then I will look for the facial nerve palsy in the John if that is present or not. Okay, all right. Then
Okay.
my command is examine the lower limb. So in the
Mm.
lower limb examination, I will see, what point do you want to see in the lower limb examination? I will see, is there any change or there is increase or decreased muscle bulk. So
Muscle.
one
Yes,
point is that, yeah, I want to see muscle bulk is reduced or not.
yes.
Okay.
Any
There
wasting
is,
or
yeah, is there is symmetrical or asymmetrical wasting of the muscles in the lower limb or not? Then you will look for any scar. Then you will look the very good points you asked. That was any hyperpigmentation or hypopigmentation. There is any
yes.
scar or the skin change, and both limbs they are bilaterally symmetrically equal, or there is reduced muscle bulk on the right side. Okay.
Okay.
Okay,
Yes.
whenever they say do the lower limb examination, Inspection is not of the other parts of the body. Inspection is just of the both lower limbs. The second step is that look for the gait. Okay, so I
Yes.
have shown you the gait. The gait was hemiplegic. Okay,
Hemiplegic. Yes.
hemiplegic gait. Yeah, I have checked for the gait. When you have checked for the hemiplegia, you will not go for the signs of the coordination. This coordination heel shin test that is basically done whenever you get a taxi gait.
A
You will not
taxi gate.
go
Yes.
for
Mm.
limb length discrepancy. Yeah, there is limb length discrepancy, but limb length discrepancy that is a part of your intelligate, that is a part of your musculoskeletal system examination, not in the CNS examination. In the CNS examination, limb length that is actually reduced or increased due to the nerve problems, due to the stiffness. Okay, but limb length discrepancy is basically a part of testing of the musculoskeletal muscles, a problems where the patient is coming to you with an intelligent care, where I am suspecting there is any joint abnormality present. Okay, so you
Okay.
have seen
And
for
it
the
means in neuro, we should not ask about limb length
no, no,
discrepancy.
not at all. That is just giving you
Oh,
was there antiseptic arthritis or was that due to
okay.
DDA? Okay. In the CNS,
Okay.
limb length discrepancy is nothing to do with the diagnosis. Okay. Now I have seen
Okay.
this is a case of the hemiplegia. Why?
Plegia, yes.
There, yeah, this is a case of hemiplegia. See here, if we see this child,
Yes. Yes,
sorry,
circumduction gait and
yeah,
knees extended, and also folk sign on his
folk
wrist
sign.
making.
No, no, folk sign is the that when there
Flex
is
is
no any.
forearm, and
Yeah,
this
I,
fist
I
is
will
towards
tell
his
you after
body.
that what is folk sign. This is not a folk sign. Folk sign is
Mm.
actually we ask the patient to move, to walk with the foot inverted. Okay, whenever you do
Okay.
not see any obvious change, any abnormality in the gait, then the subtle signs of the hemiplegia they become very obvious by performing the folk sign. Okay, we ask the
Okay.
patient to move with your foot inversion, foot inwards, and then you walk. Okay, all
Okay.
right. So
But
just
we cannot comment on this, and
no,
this
no,
is
this is
like
not a folk sign. No, this is not a folk
okay.
sign. Okay, now see
Mm.
here the walk. How will you describe the walk? If we talk about the lower limb, okay, if we talk about
Yes.
the lower limb, the leg, the knee joint, and the hip, they are extended. Okay,
Tended,
there
yes.
is, yeah, that is extended on the right side. If we look at the foot, there is plantar flexion of the foot, and the
On
foot is
flexion, yes.
yeah, foot is plantar flexion, and that is inverted. And if we see the walk of this patient on the right side, there is a tiptoe walk. Or these are the points
Tiptoe,
when you are going the
yes.
description. Okay, when you will describe the. You didn't give me any opening sentence. We will discuss that. But see here right now, I am just telling how you will describe the hemiplegic gait. My findings are
Okay.
confined on the right side of the patient. Okay, there is asymmetry, there is asymmetrical findings. On the right lower limb, there is extension or stiffness of the hip joint and the knee joint.
Knee joint.
There is plantar flexion and inversion of the foot, of the right foot. Okay, and the patient has
Okay.
tiptoe walk on the right side.
Yes.
Okay, in the upper limb, there is the upper arm, the upper right arm that is flexed and that is held in pronation. It is flexed
Held in
and it
pronation,
is
yes.
pronated. Okay. So when you will
Okay.
describe today, I have examined 6 year Johns after the opening sentence who is not in distress, no device attached. He is pink at
Yes.
room here. He is well oriented in time, place, and person. Okay.
Yes.
But all right. Then after that, you will describe the findings of the inspection. The muscle bulk that is reduced in the right lower limb. There is
Okay.
extension and stiffness in the right leg, along with plantar flexion and inversion of the right foot. In the right upper
Good.
limb, that is held in the flexed and pronated position.
Pronated position,
Okay,
yes.
my findings are confined on the right side of the patient. Okay, in the form of
Yes.
increased tone, decreased power, and upward plantar reflex.
Yes.
Okay, okay. On extension of my examination, there is right sided upper motor neuron facial palsy. This is the description. If the facial palsy is not present, then you will tell there is no accessible cranial nerve palsy.
Oh, ma'am, in this patient, there is facial palsy.
No, no. In this
John?
patient, we cannot see the face, but otherwise, whenever, every time you see this is
Mm.
a case of the hemiplegia. What is your next
Yes.
step? You have to decide: is that crossed hemiplegia or uncrossed
Yes, yes. Crossed or
hemiplegia?
uncrossed hemiplegia, yes.
Crossed or uncrossed,
Uncrossed,
that would
yes.
tell, yeah, okay. If of the same side,
Mm.
like if there is abnormality on the right side and the upper motor neuron facial palsy of the right side, this is called of the same side, that is uncrossed.
Uncrossed,
Uncrossed
yes.
means, yeah, it is uncrossed means the lesion is at the level of the internal capsule.
Inner capsule, yes.
Okay, so this is just to define where is the problem. If you see a
Problem,
crossed hemiplegia, there
yes.
is hemiplegia of the leg and the right upper limb on the right side, but there is
And facial
lower
palsy on the
motor,
other side.
yeah, lower motor neuron facial palsy, that usually
Palsy, yes.
that is of the
Mm.
opposite sides. Then usually the
Mm.
problem is at the cerebellopontine angle, or we see that is
Mm.
present below the internal capsule, or we can say that is infratentorial lesion.
Infertentorious.
Infratentorial lesion. Okay.
Yeah.
So right after deciding this is a hemiplegic gait, you must always look is that crossed or uncrossed hemiplegia.
Yes.
Okay, now the point is that sometimes the examiner will say examine the lower limb. When he say just go for the examination of the lower limb, now see here, sir, I would like to extend my examination by doing the examination of the upper limb, by
Upper limb,
doing,
yes.
yeah, by looking for the accessible cranial nerves to complete my
Yes.
examination. See, the patient has hemiplegic gait. Now you will turn to the examiner. Sir,
Mm.
I see
Yes.
some abnormality in the upper limb and I want to extend my examination. When examiner will say okay, then you will turn to the patient and you will complete your examination.
By
Okay,
looking at
okay.
cranial nerve, yes.
Yeah, looking at the cranial nerve and definitely checking for the tone power reflexes. Up first, you will do in the lower limb. You will do the superficial abdominal reflex. If this is a boy, then you will ask the examiner, "I want to check the cremostatic reflex." Okay, then you will
Okay.
do the upper limb examination and accessible cranial nerve examination when you have taken the permission. Now see here in this patient there was no need. Why? The examiner has asked you do the lower limb examination and relevant. So upper limb
Relevant.
examination, cranial nerve examination, that was a part of the relevant examination.
Relevant
Okay.
examiner, yes. Yes.
Okay. Have you checked the back for the scoliosis?
Oh, I have, I didn't, I
Not checked.
check back of the patient, but didn't ask, see any.
Okay. Always ask the patient to touch your toes. That was important. If you wish want to see, is that any acute problem or chronic problem? Okay.
Please repeat, ma'am, what you say.
Just the chronic problem. When the problem is chronic, definitely due to sustained change of the posture, there is some change in the position of the spinal cord too. Okay.
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 Now,
All
what
right.
command we should give to patient for this?
Touch your foot with touch your foot.
Touch,
Touch your toes.
touch. Okay.
Okay, all right. So this was a case of the hemiplegia. Tone power reflexes. The points you missed, that was number one, blood pressure. That
Blood
was
pressure,
number two,
yes.
fundoscopy. Okay, that
Endoscopy,
was
yes.
number
I
three,
have.
cardiovascular examination. S1,
Mm.
S2, and 0. Okay. Abdominal
Okay.
examination, that is not very much important. Here, you will not take the name of the nephrotic syndrome. Why? Please do remember for nephrotic syndrome, they will not give you a patient of the stroke. Okay.
Mm.
Nephrotic syndrome will have nephrosis on the face, then you have to
Okay.
follow that. Okay, if this is a case of
Mm.
the sickle cell anemia, he or she will have he will have sickle cell anemia on the face in the form of the pallor and the jaundice. If he is coming
Mm.
to with the gait abnormality, then you will see this is a case of sickle cell anemia. Please do
Yes.
remember in your clinical short cases, in your clinical examinations, it's not, you are not going to manage the hemiplegia. You
Mm.
are going to investigate the John. Okay?
John, yes,
Yeah,
patient.
sometimes John in the exam is coming to you with the stroke. Sometimes the John is coming to you with cerebrovascular accident. Sorry, I mean
Yes.
any vascular malformations. So my clinical
Customer.
examination has to say, is this a thromboembolic phenomena due to serious problem, or was that a stroke due to meningitis, post-meningitic
Yes, it's
sequelae?
an infection. Yes.
Okay, was this is a case of the hemiplegia was due to is this a case of cerebral palsy, or is this a case of post-meningitic sequelae, or is this a case of the rheumatic heart disease coming to me with the stroke? Okay,
Yes.
in the exam I am not going to tell all the things which have been written in the book. In my clinical stations I have to see what is the diagnosis of the John. So I will just
Okay.
do one, two, or three investigations. A book, the book will give me a table of 16 diagnoses. I have to
Yes.
pick three or four diagnoses in the patient who has come in my examination hall. Okay,
Okay.
okay, all right.
Yes.
Okay, so today I will discuss some points about the gate, not for like your exam, but please do remember when you get more and more knowledge, this will boost your exam. This will boost your confidence, and this is only
Yes.
the game of the confidence that you will display in your real exam. So, what is gate? This is gate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 steps. I am just putting my foot on the floor. I am just getting my foot off the floor, and it is taking 10 steps. That is very important. See here, very important. Why in some point you say there is a short stance for the intelligent gate. So any gate that has two phases, one is called that is the stance phase, and one is called the swing phase. So when you are able to put your foot on the floor, this these 1, 2, 3, 4, 5 steps. These 5 steps are needed to just to put your foot on the floor. And after that, when you are just moving forward, you put your foot on the floor, then you keep off the floor, you put your foot in the air, then again on the floor. So just keeping it on the floor, taking it in the air, then putting again on the floor. This is called a gait cycle. Okay, so just putting that on the floor, this is called a stance phase. When your foot is in the air, that is called a swing phase. Your
Spring
stance
face.
phase, that is of the 60%, and that is of the 40% of the cycle. Now see here, we see first what we do, initial contact, that is with the heel. Okay, initial contact, that is called a heel strike. Foot first touches the ground. Why this is very much important? Here the problem, that is of the neuropathy.
Yes.
Okay, okay, we see some patients, they have tiptoe walks. They cannot put their heel on the ground. So this is important for neuropathy. When the patient is just keeping having a tiptoe walk, putting the tip of his foot on the floor, not the heel, so that may be a case of the upper motor neuron lesion. Okay, so then comes a foot flat, body weight transfers onto the foot. Now see here, he was just putting initially his heel on the floor. After that, he has flat foot. Now the whole weight of the body that is transferred over this foot. The patient who has
Foot.
joint problem, what will they do? They will not be able to keep the whole weight of their body on their foot. So these patients will have short stance phase. This is very typical of an intelligent gait, where we'll describe in a very typical way. The stance phase of the patient is short, So that is why more likely this is an antalgic gait. This patient is having any problem, maybe in the knee joint, maybe in the hip joint, when he is putting all his weight, transferring from this joint to the foot, he feels pain and he doesn't put all the foot flat on the ground. Okay, then
Okay.
the stance body moves over the supporting foot. So these two phases in the intelligate they will be very much shorter. Terminal stance, heel is off. Heel lift as weight shifts to the other leg. Now from this side to this side that is shifting. So what will do? Here the pelvic girdle will help. Shift, see here that is, suppose that is the pelvic girdle. Shifting the foot from this side to this side. Here the weight will be transferred from taking help from the pelvic girdle. So this pelvic girdle that is supported by your gluteal muscles. There are some gaits which are due to proximal muscles problem, like your rattling gait. So here there will be a pelvic tilt that will be present. Now just see it, like each step of the stance phase that will define where is the problem in the gait. Okay, in the
Okay.
myopathic, this terminal stance phase that is very much difficult. So there is a pelvic tilt just to support the weight from this side shifting towards another side. Okay, then is a
Mm.
pre-swing. Toe pushes off the ground for propulsion. Now the toe is off, but the patient who are having the upper motor neuron lesion, they will have problem in this one. They will put their toe on the ground. They have difficulty in putting this toe off the ground. Okay, each phase is decided sometimes by the muscles, sometimes by the nerves, sometimes by the upper motor neurons. Okay, so that is next time, that is in the swing phase. This phase comes when foot leaves the ground, ends when it touches the ground. Okay, if we talk about this one, this is not going to decide any abnormality, like the very much the clear points.
Mm.
These all the neuropathy, myopathies, they are usually decided on the stance phase. Okay,
Substance,
alright. So
yes.
these are the two phases of the gate, just for your understanding, just to boost your knowledge. It's not like giving you any help in your exam. Okay, now in the exam I have seen, this is my patient who is coming to me with this gait. Today I have taken the case of the hemiplegia. That is why I have taken, see here, this is the stiffness that is present. Hip joint, knee joint that is stiff, hip joint that is flexed. So why they are flexed? There is a problem. There is basically the extensors of the hip joint, extensors of the knee joint, they have become very much extended. There is problem in the total straightening of these legs. Okay, and there is a plantar flexion of the foot, and it is inverted, it is slightly going inside inward. Now see here that is inverted, and it is also describing the circumduction. Why circumduction? They cannot be flexed, so they are straightened, they have become stiff, and for their stance, for their swing phase, they just keep their foot off the ground in a circumductive way. Okay, and there is a
Okay.
slight tilt that is present, the pelvic girdle that is slightly shifted upward on the side that is affected. Okay, this is just to
Okay.
overcome the effect of the gravity, like the upper limb that also has been flexed and pronated. Just one, it is adducted, it is flexed, and it is pronated. These
Native.
things they are very important when you have to describe. Try to describe the hemiplegia just in 20 seconds. It's just a hemiplegic gait in 20 seconds. Otherwise, all relevant features you should take total 45 seconds for
Okay.
describing your patient positive findings and giving the examiner to some diagnosis. Okay?
Okay.
All right. Now, this I have taken from your Secrets of MRCPCH Clinical Exam. Very interesting, very good book. Please do give a reading to that book, The Approach of Hemiplegia, Approach of Diplegia. Okay. So, when the examiner asks you, examine the lower limb. The first step in all the examination that is inspection. action. So we will say there is asymmetry. There is decreased power, muscle tone, okay, which are present on the right side. You will describe that, okay. And if you want to measure, you should measure by a measuring tape, taking this tibial tuberosity as your reference point 5 centimeter below, okay, and measure, take a measuring tape and measure the leg, this circumference of the leg, okay, on the both side. So you can ascertain, you can document there is asymmetry, there is decreased muscle bulk on the right side, okay. Okay, no scar,
Okay.
no hyperpigmentation. Okay, ask the patient and the parents, can the child walk? Look at the surrounding for the walking aids, wheelchair, or rollators, like your orthosis or special shoes. So these are
Okay.
very important things. No device, no distress. We have taken no device, no distress, no dysmorphism are unusual features. The child is pink at room here, so I have ruled out this is not due to cyanotic congenital heart that has caused the thromboembolic phenomena. Okay, then you will ask the
Yes.
patient, can you walk to the front and turn back? Ideally left with the shorts are okay. So this is for your exposure. Observe the gait and arm swing. Observe the
Yes.
turning. A turning that will tell you if there is an ataxic gait present or not. Okay. Okay. When you have asked the patient to do these maneuvers, you should move side by side. See here, can you please, John, can you please walk for me? John is walking on this line. You have to move along the John. Why you're not sure is that an ataxic gait, hemiplegic gait, or what else? If there are chances John may fall down, you should walk along the John. Okay,
Okay.
ask the John, work in fast mode. If the child is having hemiplegia, you will not say run or not. These are the steps you will do when you are not sure, when you are not certain. There are very subtle changes. You cannot say confidently this is an hemiplegic gait. Okay, then you say walk in fast mode. Then you say walk with foot in inversion. This is called a folk test. Subtle hemiplegia, subtle diplegic gait may become more obvious, more apparent when you will go for folk test and when you will say just move in a fast mode. Okay,
Okay.
you
Okay.
got this? Okay, okay. Now
Yes.
he has gone for the folk test. I couldn't see the gait, seems to be normal. Then you will ask him walk on tiptoe. The patients
Tiptoe.
who have neuropathy, okay, they cannot have a tiptoe walk,
Yes.
right? They have
If
high
patient is already
steps.
walk on tiptoe like this patient, even we have to
No,
say walk on
no,
tiptoe.
no, not at all. No, no, no. See, Dr. Tanveer, these are the steps. Now, see here. In this case, I will not go for run fast, tiptoe
Yes.
walk, walk within. No, when there is some ambiguity, the child, there are some videos where you will see
Okay.
now seems to be normal, seems gait seems to be normal. I do
Yeah.
not find any abnormality in those. When the
Those cases.
examiner
Yes.
have asked you examine the gait, then you will complete
Okay.
all the steps. Definitely not in this case. This is
Yes.
very obvious hemiplegic gait. These
Yes.
are
Yes.
done when you are not sure, when there are very
Yeah.
little subtle changes. Okay. Walk on the
Okay.
tiptoe. Patient with a spinal cord lesion below the L5 will fail to do this. Okay. Walk on the
Yes.
heel. The patient with the foot drop, like the patient who have neuropathy, spinal cord lesion below L4, will fail to do this. The patient who have neuropathy, spinal cord lesion below L5 will fail to do this. The patient who have neuropathy, spinal cord lesion below L4 will fail to do this. The
Hello.
patient who have neuropathy, spinal cord lesion below L5 will fail to do this. The patient who have neuropathy, spinal cord lesion below L4 will fail to do this. Okay.
Hello. Hello.
Hello. Okay.
Yes.
Okay. I think some problem. Okay. So now you say tandem walk children. 5 years and above to elicit subtle ataxic gait. Okay, do remember these are the steps when we are not sure, and we have to make sure is there any abnormality in the gait or not. Okay, when the
Gate.
child has done, okay, I have a certain, so after gait I have a certain, this is hemiplegic, this is spastic gait, ataxic gait, pedaling gait, and after that
Yes.
I will follow their approach. Okay. All right. They
Okay.
say if you cannot commit to yourself what gate it is, describe what you see and proceed with the lower limb examination. Okay. If the child has waddling gait, so we will not talk about a waddling gait here. Today I will talk about the hemiplegic gait.
Hemiplegic
From
gate.
every student, I will go for one gate examination. Okay, from you, you have done hemiplegic. The next student, I will give some maybe sometime ataxic gate, waddling, and all this. Okay, when waddling
Yes.
gate is present, then you will go for Gower sign. You will not go for
Because it
Gower sign for hemiplegic
happens in
gate.
myopathy.
Yeah, we will go according to their approach. Now see here,
Okay.
approach to the hemiplegic gate. So I have asked the patient. This is hemiplegic gait. Ask the child to run and perform fog test if subtle, right? Then do
Yes.
upper limb and lower limb examination. According to your command, your task, if the examiner has asked just for the lower limb and relevant, you will need to take permission for the upper limb. If he just has asked you to the lower limb examination, then for you will take permission from the examiner. I want to extend my examination. Okay. After the
Okay.
hemiplegic gait, my first step is make sure is that crossed or uncrossed hemiplegia.
Uncrossed. Yes.
Yeah, okay. Lower limb examination means you will do the tone, you will check the power, you will check the reflexes of the both lower limbs. Okay.
Yes.
You will check the tone, you
Tone
will
power
check the power
reflexes
and
and
reflexes
also
of both.
plantar also
Yeah, they,
in
that
lower
is
limb.
must. Planter
Yes.
is a must sign. Okay. Then they have
Yes.
given you the next approach. If you see the same side lean that is a uncrossed hemiplegia. So
Uncrossed.
you will see, yeah, this is most likely the lesion is at the side of the internal capsule. One another
Mm.
finding that may be there is homonymous hemianopia, but that is usually you do not have enough time to go for all these examination. Okay,
Yes.
you will not have enough sign to look for the parietal lobe signs. Okay, I will show you what are the parietal lobe signs. Parietal lobe signs are basically when the patients they are not aware of their real position, like they are not they cannot make sure they are sitting on the sofa or the furniture is near to them. Okay, there is problem in the understanding. There are some signs I will show you which are known as the parietal lobe sign, but in the real exam you usually do not have these much time to make sure this is parietal lobe signs present or not. Okay, this
Okay.
much is enough. You have gone for the accessible cranial nerves. The first nerve that is
Cranial
the
nerve.
facial
Yes.
nerve. I have decided this is crossed or uncrossed. The next, if you have time, just go for 3, 4, 6 accessible cranial nerves examination. That is your eye examination. Okay. All right.
Yes.
Then after that, you will go for head examination, not before that. That was a part of your relevant examination, but not before
Mm.
that. Now, see here,
Mm.
if a 6-year-old child is not going to
Even,
give me,
ma'am, in this even
yeah,
in general observation, we have not comment on this.
no, you will
What
comment,
about head
but
size, shape, like this?
you will definitely comment. But see here, your task was do the lower limb examination, but you
Yes.
told me right after washing my hand, I will look at the head. No,
Mm.
after that, you will look at the head. You will look for the
Okay.
size, shape, sutures, scars, and chin.
Mm.
Now, see, if the 6-year-old child, he will definitely not having shunt unless he was a
Yes.
previous case of the hydrocephalus. Okay,
Yes.
very less likely he's coming to you with the hemiplegia with the scar. He very
Yes.
less likely is having the sutures. Okay, so according to your patient, you will change your things. But yes, you should look at the say, head circumference. Maybe that is having any microcephaly. Maybe he's having any dysmorphic features which are present. Next is a serious examination. Okay, next that
Yeah.
is very simple. The skin examination. You have asked about the tumors, but that was not the tumor in the abdomen. That was a brain tumor which has
Brain
caused.
tumor. Yes, yes,
Yeah, okay. Now see here, just one, two, three, four steps. Now remember from today. It's just your skin examination, it's just your CVS examination, okay? Like a normal child. It's not your stroke may be present, but not in this case.
yes.
Okay?
Okay.
Okay, these are the approach of the crossed hemiplegia, right? What are the
Yes,
causes? These are VIPs. V stands for vascular, I for infection, P for pressures, and S for SOLs. These are brain tumors. Okay.
tumor. Yes,
In
yes, yes,
underdeveloped countries, infection would go on the top, like in Pakistan, in Bangladesh, in India. Your meningitis, your encephalitis, your brain abscess, that would go
yes,
on the top. Okay. But here,
yes,
now see unilateral hydrocephalus. Hydrocephalus is written on the face of the patient. If this is a case of the hydrocephalus, you will not say in John like this why. You will not say here, this is a case of I would like to rule out SLE, I would like to rule out
yes,
hydrocephalus. No, not at all.
yes,
This may be a case of infection, this may be a case of vascular malformation, and I should
no,
always comment on the CS first and second heart sound that is normally audible, there is no added sounds. Okay.
yes,
So what other countries, developed countries, the causes, these are AV malformations, non-accidental injuries, periventricular hemorrhages depending upon the age, thromboembolic phenomena, cyanotic congenital heart but John is not, cardiac surgery but John is not, infective endocarditis but John is not, SLD, John is not, Takayasu,
yes,
yeah maybe. This is not a case of homocystinuria will come to you with the developmental delays. Okay,
yes,
SLE
yes,
and
yes.
pathologia. So you have to put your diagnosis according to presentation of your patient. Okay.
Okay. Yes,
All right. If it turns out to be a case of the crossed hemiplegia, in the crossed hemiplegia, there is contralateral lower motor facial weakness. That is very
yes. Lower
important.
motor
Why?
neuron facial palsy.
Yeah. Okay. So the problem is infratentorial. Then we also have to see other cranial nerve palsies, accessible cranial nerve examination. That is also important. But whenever there is lower motor facial palsy, the cerebellar signs become very must. Why? The problem is in the cerebellopontine angle. So here is the cerebellum, here is the pon. Cerebellopontine angle, if tumor there is present, it will cause crossed hemiplegia. So for that you have to see along with this facial palsy, other 7 and 8th cranial nerve assessment, and along with that you should go for cerebellar signs. Clear?
Okay,
Clear. Now, today you will memorize this approach. That is very important. Approach to hemiplegia. Crossed or uncrossed. In the crossed, you have to see the cerebellar signs. In the uncrossed hemiplegia, you will go for CNS examination, definitely in both your heads, your CVS, and skin examinations. Okay?
okay.
Clear? All
Yes,
right. Okay. How would you manage and how would you investigate? Investigation would depend upon. Now, will you go for MRI brain? Yes, we will go for that. I will go for fundoscopy. I will go for MRI brain. I will go for electrocardiogram. I will go for echocardiography. CVS
organic.
may be
Yes,
cyanotic, maybe acyanotic. Acyanotic patient may come to you, but that would be diagnosed on just on your echocardiography. Is there any
echocardiogram.
thromboembolic phenomenon? Yeah, okay. All right.
Yes,
So, okay. So, next, that is for the hemiplegic gait. How will you manage this case? There is always a general management and a specific management,
okay,
right? Multidisciplinary approach. You will tell all this. I will, first of all, I will confirm my diagnosis, then I will manage accordingly. That is the answer for your specific management. First of all, I will
okay,
confirm my diagnosis. Then this is there is a multidisciplinary team. that is important. Occupational therapy, that is important. Social worker, that is important. So
Yes.
financial support, that is a part of your general exam management. Counseling of the
Mhm.
parents, psychiatrist, psychologist, these are general steps of the management. For
Yes.
specific management, I will confirm my diagnosis and manage accordingly. Then examiner,
Okay.
if you they have enough time, he will say, if it turns to be a case of vascular malformation, what will you do? Okay,
Okay.
all right. So these are the steps basically for your parietal lobe signs. So parietal lobe signs are basically these patients. They do not have any assessment. They cannot recognize the shapes, right? They cannot assess what they want to do, like how much centimeter is this table away from me, how much my head position is along with this bed or along with this sofa. That is called spatial orientation. This is a part of the parietal function where the coordination and the balance, that is not judged by the patient. Okay, he
Also,
doesn't
it
know about the
affect deep
spatial
sensation,
boundary.
like this.
Sorry.
Deep sensation also affect in this case.
Yeah, they are also affected. Now see
Mm.
here, actually they have problem in the maths, they have problem in reading, they have problem in the writing. These are non-parietal lobe signs. For our examination point of view, we just need to know that they do not have good handwriting, they have problem in the reading, and they have very specific problem in the calculations in the maths. They also
Okay.
have speech problem. This is basically coordination and balance problems. Okay.
Okay.
All, all right. So that was for today's class. The next time, inshallah, we will do that this week with the CNS systems. The important things to do for clinical station in the CNS. One is your gait. Okay. One is your
Yes.
neurofibromatosis, like the
Okay.
neurocutaneous syndromes which are coming. So these two stations, they are very important. Ataxic gait, your Duchenne's muscular dystrophy we will do with the musculoskeletals are like with musculoskeletal system we will go for DMDs and all others. With the CNS we will go for gait abnormalities, microcephaly, macrocephaly, okay, hydrocephalus,
Okay.
and eye problems.
Okay.
All right. Okay. Thank you so much. Any questions?
No, ma'am.
Okay. Allah Hafiz. Good night.
Okay. Allah Hafiz. Bye bye.